Good afternoon, ladies and gentlemen. My name is Maximilian Klar, and I'm delighted to introduce you today to a talk on cervical and endometrial cancer patient treatment. This is in the context of a series from Freiburg, Germany, which is called Cutting Edge Knowledge Shared by Leading Freiburg Gynecologists by the International Medical Service of the University of Freiburg. Again, I welcome you and I wish you a very informative talk in which we can share our thoughts and considerations about cervical and endometrial cancer treatment during the lecture and also afterwards. I am now ready to share my slides. Here we go. So I'm just to introduce myself, I'm a gynecological oncologist working in the southwestern corner of Germany in a town called Freiburg, a university town of 220,000 inhabitants, with more than 20,000 students, living close to the Black Forest and the Rhine Valley, close to Switzerland and France. A very beautiful area to live in. We have a comprehensive cancer center which takes care of our gynecological oncology patients in terms of systemic and surgical treatment. My training was based in Australia, where I pursued a gynecological oncology fellowship for 1.5 years. I'm a robotic surgeon as well as an open surgeon, but have concentrated over the past years in minimally invasive techniques. So I do receive honoraria for invited talks by JSK Cooper and KLS Martin, and my talk is divided in 3 parts. The first part is on cervical cancer screening, the second part on the surgical treatment of cervical cancer patients, and the last one about changes in the systemic treatment of endometrial cancer patients with new results from the DUO-E study, which were presented at the ESMO conference this year. Now, as I know you are from foreign countries, I would like to start with a topic that is often discussed when professional experts from other countries visit us, in questioning the way how we provide a national screening program in Germany as compared to their country. So I believe this could be of interest for you as well. Let's start with cervical cancer screening. Cervical cancer is a preventable disease through vaccination and screening programs. The WHO has therefore provided a global strategy for the elimination of cervical cancer patients through the 90-70-90 targets, which have to be met until the year 2030. 90-70-90 means 90% of girls should be fully vaccinated with the HPV vaccine by the age of 15. 70 means 70% of women are screened with a high performance test by the age of 35 till 45. And 90 again, meaning that 90% of the women identified with a cervical disease should receive treatment in their area. So 90, 70, 90, and we will see how Germany, my country, as well as other countries perform in these 90, 70, 90 regards. As you know, the incidence is quite different around the world. We have high incidences where screening programs do not exist and where vaccination programs are also scarce. So, for instance, Europe has, especially Western Europe, has low incidences, with cervical cancer screening programs being present and vaccination uptake being moderate, but at least to some extent present as well. Australia has one of the lowest incidences in the world, but especially the Southeastern Asian countries and the African sub-Saharan countries show high incidences, but also, and this is what you see below, high mortality rates. The ultimate goal of any screening program is to reduce the age-standardized incidence and mortality. So it's not sufficient to provide a test with a high sensitivity and specificity parameter, but it has to be a test that in the end reduces incidences and mortality of the disease. Geographically, Africa has the highest cervical cancer incidence and mortality globally. And as you know, HPV vaccination uptake in these low and middle income countries, especially in sub-Saharan Africa, is low, with only 1 in 5 adolescent girls receiving a vaccination so far. This is data from the WHO in 2020. In Germany, cervical cancer is not the most the most prevalent gynecological malignancy. This is endometrial cancer, but cervical cancer is only present in roughly 4 in 100,000 women, and the age standardized mortality rate is 2.5. You can see here that from the 2000s until now, the incidence rate has been more or less stable, even after the introduction of HPV vaccination as a general strategy in low-risk populations. The mortality rate as well has been stable. So we can see a similar development of incidence and mortality in Australia, for instance, which has led in 2014 in Australia to change the screening strategy and to focus on HPV test screening only, whereas in Germany, cytology screening is still a present and valid strategy, which I will show you in due course of this talk. But HPV vaccination is a highly effective preventative program for low-risk populations. And if you're not convinced so far, please have a look at this New England Journal graph, which was published in 2020. These are data based on a large cohort study of more than 1,700,000 women who were screened for cervical cancer being present or not, and then looking back in the retrospective data, whether they have received HPV vaccination or not. And you can see here that the unvaccinated population is the population at risk. It is the unprotected population, which is shown in this graph here, the orange line rising up exponentially for the cumulative incidence for cervical cancer, which is the unvaccinated population, whereas here the vaccinated population below the age of 17, so receiving 2 or 3 doses of the vaccine below the age of 17, has almost a stable, very, very low incidence of cervical cancer. And interestingly, this is not only a Kaplan-Meier curve or an incidence curve here, I should rather say. It is also after adjustment of all covariates, such as smoking or social status, etc., that the incidence rate ratio was 0.12 among women who had been vaccinated before the age of 17 and 0.47 among women who had been vaccinated at the age of 17 to 30 years of age. So we can see a highly significant independent protective effect of HPV vaccination in women in regards to the risk of developing cervical cancer. Now, how is this strategy implemented in Germany? Let me just present you quickly the recommendation of our STIKO committee, which is the National Vaccination Committee, and it recommends that girls and boys should be vaccinated against HPV, ideally between the age of 9 to 14 years. Up to the age of 17, the mandatory health insurance covers the costs of a catch-up vaccination. Vaccination does not replace early detection, though. Now, these are data from our regions in Germany. You can see my place here being close to the Black Forest in the southwestern corner, as I said, Freiburg. And what is interesting here, as this is not a mandatory HPV vaccination strategy, but a voluntary strategy, that we do not have a high uptake of the primary prevention program, unfortunately. There are some regions in Germany, especially in the former Democratic Republic, Eastern Germany regions, where the uptake is a little bit higher, with 70%, 65% here. But in the southern parts of Germany, the HPV vaccination uptake is rather low, with less than 50%. And this is quite astonishing and disappointing, to my opinion as well, that we have not, despite the wealth of the country, developed a functioning HPV strategy here. One of the reasons why the uptake is so low may be that we do have a system of office gynecologists, office pediatricians, and office GPs, and maybe, but this is just a hypothesis, no one of these three groups of medical doctors really take care and responsibility for providing in a general rigid manner a HPV vaccination program in the office for these healthy young kids. You can see here Mädchen, meaning girls. Here, the gynecologist plays an important role from the age of 15 to 17 and afterwards. But before, more the pediatricians, especially between the age of 9 and 14. Obviously, there's no gynecologist for the boys, but here you can see that the most important doctors who provide vaccinations are the pediatricians. And the uptake is lower the older the kids become. So after the age of 18, the uptake decreases tremendously, whereas before first sexual intercourse, the uptake is rather high, with a highest level being reached at the age of 15, but again, only 37% of all women. And there are many hypotheses discussed also in the media. This is a focus analysis providing an overview of why maybe HPV vaccination have decreased in kids and adolescents. against cervical cancer and HPV-related diseases, and a tremendous drop or decline in HPV vaccination rates has been observed after the COVID pandemic in 2020. So overall, roughly, and this is true for any society, not only in Germany, we need an overall vaccination rate in the low-risk population of 85% to provide a stable primary prevention strategy. And in our country, the completed vaccination rates among 15-year-olds, only 51%, and boys only less than 20%. And the Lancet has published in 2020 a population-level effectiveness of analysis. This is a mathematical analysis of only a one-dose HPV vaccination program in low and middle-income countries. And this is interesting because it shows that even after just one dosage, there is a protective effect of HPV vaccination in regards to developing cervical cancer or HPV-related diseases. So this is not only an effective strategy perhaps for low and middle income countries, but also for Germany, as people seem to be reluctant in providing or receiving HPV vaccination. So when it comes to secondary screening programs, there has been a change in the way we detect early stages of disease, cervical interepithelial neoplasia, in the lowest population. And the change was started in 2020 with a algorithm that is different for women under the age of 35 and after the age of 35. So in younger women, a yearly cytology is the screening strategy, and these are different cytology results. It's not the Bethesda classification, which you know. It's rather a different classification system, which is called the Papanicolaou classification system. But basically what it says here is once there is a severe dysplastic lesion detected cytologically, immediate colposcopy has to be performed. But in terms of uncertain cytology results, in general, after 3 months, a colposcopy has to be performed as well. Here, mild dysplastic lesions or inflammatory lesions can be combined with an HPV test and cytology smear again after 6 to 12 months. This is the strategy, a cytology-based strategy for women below the age of 35. After the age of 35, a combined cytology and plus HPV tests every 3 years are performed. In the cases of, this algorithm and triage is HPV-based, whereas this triage is cytology-based. So once the HPV result is negative, and it comes back negative as well in a cytology screen, the woman goes back into general testing. However, if the HPV test comes back positive, it depends on the cytology whether or not a colposcopy is recommended. And this is the case if cytology shows the moderate degrees of dysplasia or severe degrees. Now it's interesting to compare this strategy, this quite unique German way of cervical cancer screening with other countries. And for instance, one may wonder when does screening actually start? And we said here before that we start at the age of 20 and do have a stop, no true stop after the age of 75, whereas many other countries have recommended to stop screening at the age of 65, as you can see here, and to start even sometimes a bit earlier, or sometimes also around the age of 21. Right, so the start is rather similar in an international comparison, whereas the end of screening is quite different with most countries like the United States or other countries such as Austria and Denmark, as well as Japan, stopping at the age of 65. And it's also interesting to have a look who actually recommends which strategy to follow. And in some countries, it is the Cancer Society, such as in Switzerland, Norway, or the United States. Whereas here in Germany, we do have a national guideline committee, and this is a mixture of many different organizations, such as the cytology organization, the colposcopy organization, the gynecological pathologists, etc. So there's a large mixture of interests who influence the way we recommend cervical screening should be done. Here is the Australian way, which has been changed, as I said before, in 2014, after the incidence and mortality rates have discovered to be stable on a low level, but not low enough for the authorities. So here is the proposed cervical screening pathway with an HPV triage. So there is an HPV test at the beginning with partial genotyping. If the test comes back unsatisfactory, it has to be done, a retest has to be done within 6 weeks. But if the test has a satisfactory results and comes back with the high risk HPV contamination, 16, 18, plus minus 45, it indicates already that there is an HPV infection ongoing. And this automatically leads to the recommendation to refer to a colposcopy unit with a reflex liquid-based cytology result. For all other types, it depends a bit. So you can do with the same smear in the same vial already a cytology. And this helps you to triage further. So if, let's say, for instance, there is HPV others positive, then a liquid-based cytology is performed. And if a high C lesion is detected, this will lead to the automatic recommendation to refer to colposcopy. Whereas here, if the liquid-based cytology results provides result of a low C lesion or even a negative cytology, a repeated HPV test is recommended in 12 months' time. So only here, if the HPV test comes back positive, again, there is an automatic referral to the colposcopy unit. Last, if the HPV test comes back negative, then a recall for screening is recommended, but only after 5 years. So that's quite a different strategy as compared to the German way. So let's have a look for screening methods in low and middle income countries. First, cytology only. Well, what we know about cytology only, that is our knowledge before the HPV testing has become prevalent in our countries. So cytology only is certainly an effective way to detect early lesions such as CIN 1, 2, 3 in the low-risk population. It has been shown to decrease the cervical cancer incidence from 40 in 100,000 women in Germany to, in the 1970s, to now 8 per 100,000 in the recent years. So it is effective in organized screening initiatives and has led to a drop in the cervical cancer incidence and mortality. There are, however, some issues with cytology testing only in low and middle income countries. Cytology has, for instance, failed in many attempts and studies due to the need for sometimes repeated testing, for its need to provide, to have, or to be dependent on healthcare resources and infrastructures, cytopathologists, colposcopists, and pathologists, laboratory supplies. Sometimes women need to show up more than one time. So a screen and treat strategy is difficult with a cytology-based screening. High-quality smears are difficult to obtain sometimes, and the whole process is complex and expensive, maybe in some areas too expensive. In remote areas, women should only be tested once or twice in their lifetime. Let's have a look for the combined screening, and you can see here that the detection rate ratio of HPV test plus cytology as compared to HPV test alone for the detection of a moderate plus intraepithelial neoplasia, so CIN 2 plus, is not any better if you combine the screening techniques. That's why on a European level, combined testing is not recommended as compared to single testing with HPV test alone. Here you can see also the detection rate ratio for CIN 3 plus, and again the diamond crosses the null value here and here, so no significant benefit of providing combined screening. This is a similar analysis. What we can see here is that HPV negative results will certainly have little false negative results for the detection of CIN 3 plus or cervical cancer. So HPV is a safe strategy. HPV tests only, there are many providers for the HPV tests, not only hybrid capture 2, but also other tests, as you can see here, which all provide excellent sensitivity and specificity parameters. Most existing human papillomavirus assays for cervical screening are designed to yield a pooled result for the carcinogenic HPV types. The criteria for a good quality sample are less rigorous for HPV testing compared with cytology. It allows sample collection to be performed by the patient herself, not requiring trained personnel or infrastructure to perform a pelvic examination. So this is important in many countries, such as the Maghreb countries in Northern Africa, show that the self-testing is a valid strategy as well. And this is what you can see here, self-collection versus clinical collection of HPV assays compared here, and the excellent sensitivity for the detection of both strategies for CIN 2 plus and CIN 3 plus in this publication in The Lancet in 2021. So as a conclusion, I would say that primary prevention is the way to go in our countries. We need more primary prevention programs HPV vaccination programs, not only in low middle income countries, but also in European countries. As I've shown you, we do face severe problems in the uptake of HPV vaccination. Mathematical models show that not only 3 and 2 doses are enough, but maybe only 1 dose may be enough. But lack of information and awareness exists in many societies. Secondary screening strategies are more prevalent in our countries with more experience here, and traditional cytology-only programs have come to an end due to the high and excellent validity parameters of HPV test screening strategies. HPV tests and self-tests may be the first step of the triage towards colposcopy and treatment, and this is the future of HPV, cervical cancer screening. Low-cost programs and awareness and wide acceptance in the general population are needed, with support from the ministries of health. Immediate treatment should be available if an abnormal result is detected. So this is the first part of my lecture, and I'm wondering if you've got any questions so far. Please let me know in the chat, or please interrupt at this stage. Okay, so if this is not the case, I'm also happy to continue. So in the second part of this lecture, I would like to focus on the surgical treatment of cervical cancer patients. As you know, we all are, as gynecological surgeons, are very fond of many invasive techniques. This includes robotic surgery, but also traditional conventional laparoscopic surgery. These approaches have been widely used by gynecological oncologists, especially also for early stage cervical cancer patients. The advantages of these methods are less imperative blood loss, fewer complications, faster recovery, shorter hospital stay. But there is a major disadvantage over the past years, which you are all aware of, and these are the results of the LEC trial. The LEC trial has shown a major disadvantage in terms of disease-free survival and overall survival for women treated with laparoscopic or minimally invasive surgery for cervical cancer as compared to women with open surgery. So these are significantly worse. We have lower disease-free rates, 86% versus 96% and 94% versus 99%. And this has been published in 2018, so 6 years ago, in the New England Journal of Medicine, minimally invasive surgery versus abdominal radical hysterectomy for cervical cancer. And you can see here the Kaplan-Meier curves that show a higher risk for disease recurrence, local regional recurrence, and a worse disease-specific survival. This has also been shown in many other meta-analyses, the higher risks of local regional recurrence and higher rates of death from cervical cancer as well. Now, there is a cohort study which has been published in 2018 afterwards, which has shown in a retrospective manner and confirmed the results of the LEC trial in 2,500 women with a median follow-up of 45 years, showing that the 4-year mortality rates were significantly higher in patients who were treated with minimally invasive surgery. So the minimally invasive surgery led to a 0.8% decline in the 4-year relative survival rate after 2006. And we were all shocked by the results, and the results have been confirmed in a long-term updated analyses. And the questions are now, is it the type of surgery that has led to the worse oncological outcome? Is there a difference between robotic or laparoscopic surgery? Maybe another question was, is there a difference when it comes to the size of lesion? So higher tumor size is associated with worse oncological outcome, and maybe the cutoff is at 2 centimeters. Are the results explainable through the CO2 pure peritoneum? Is it different if you provide a prior preoperative colonization prior to the radical hysterectomy? Is it different if you use a uterine manipulator rather than others protective measures? Could you perhaps avoid a spillage in the peritoneum if you do a vaginal closure before colpotomy? And is there also an effect of surgical experience? So there are many, many questions, and honestly, we do not have the answer, but we are getting an idea of why the results are as they are. And this is presented now in the upcoming slides. So first, robotic surgery. No study so far compared the radicality of the hysterectomy specimen between robotic and laparoscopic surgery, for instance. And only one study compared robotic surgery versus conventional laparoscopy in terms of the oncological outcomes, and found no statistical significant difference between the two techniques, with a disease-free survival of 96% and 90% respectively. When you compare, however, robotic surgery with open surgery, this analysis from 2018, again published in the New England Journal of Medicine, showed that in an exploratory subgroup, robotic-assisted radical hysterectomy was associated with a high risk of death compared to open surgery, 1.61, so a 60% higher death rate when the patient was operated with robotic surgery. There are 2 ongoing trials now which have focused on the effect of robotic surgery on the oncological outcome, which is disease-free survival. And these are the REC trial in Europe by Henrik Falconer from the Karolinska Institute in Stockholm, and the ROC trial from the United States. So the REC trial, to my knowledge, is about to end recruitment, and we will have the results in 2 to 3 years' time, I would say. And the ROC trial, I'm not sure, I think they have closed already the recruitment period. So these 2 trials compare robotic surgery versus open surgery in early stage cervical cancer. Again, here in both studies, the manipulator should not be used, or there should be a clear protocol for protective measures being taken. When it comes to the question of the tumor size, we have discussed in the past the better results in the tumor size below 2 centimeters. However, we have to keep in mind that the LEC trial was not designed to provide statistical significant sample size calculations for tumor size. So this subgroup analysis is not valid, and we honestly do not have the knowledge about a preferable oncological outcome in patients smaller than 2 centimeters tumor size. So in the LEC trial itself, the authors concluded that the results of the trial should not be generalized for patients with low risk, which translates here below the tumor size of 2 centimeters, because the trial was not powered to evaluate the oncological outcome of the 2 surgical approaches in that setting. But minimally invasive surgery was associated with a worse outcome in patients. Yeah, well, we do not know, and we cannot confirm or not confirm these associations, but we can have a look at the literature, and there are some studies that confirm that minimally invasive surgery has worse outcomes also in smaller tumors, and these are some of the studies, at least 4 studies, comparing the oncological outcome of patients with smaller sizes, minimally invasive versus open surgery. But again, there are other studies like these 4 trials, and one of them is the famous Sucker trial from Spain by Professor Shiva, who do not confirm minimally invasive surgery with worse outcomes in patients less than 2 centimeters. So it's very difficult on these retrospective data to draw any conclusion. And we also cannot argument with the results of the LEC trial, as this study was not powered for considering patients below the 2 centimeters tumor size. So in summary, it's very difficult to draw any conclusions. The results of these retrospective data, which I've shown you for studies for the use of minimally invasive surgery, are conflicting. The median follow-up time was different also, and the measure of 2 centimeters was also different. Sometimes we have an overestimation of the preoperative MRI scan in cervical cancer patients as compared to the evaluation by clinical examination. Patients with a tumor size under 2 centimeters represent a heterogeneous group, macro and micro tumor or no residual tumor. The hypothesis is that the use of the uterine manipulator and the exposure of tumor cells or tumor cell growth and spread enhanced through CO2. And this is now the 3rd consideration. What is actually the effect of the CO2 tumor peritoneum? So cases of intraperitoneal dissemination after minimally invasive surgery for cervical cancer patients have been reported. And the possible reasons are that there is an intracorporeal colpotomy and therefore an exposure of the tumor cells in the gas of CO2. The high pressure may also lead to a tumor cell implantation, and the acidic environment of CO2 could promote tumor growth in general. The acidosis of the intra-abdominal environment suppresses the peritoneal immune system. That's one explanation. Or the acidic environment induces damages to the peritoneum. And these are all potential explanations why patients with a long exposure of the CO2 tumor peritoneum may have worse oncological outcomes. So the CO2 needs tumor cell exposure, and without the tumor cell, CO2 can do nothing. Well, so what if we block the contact of the tumor cell and the peritoneum, and what about the crucial step of the vaginal colpotomy in order to break the contact between the tumor cells and the peritoneum? So this comes now to another consideration and crucial step, which is the vaginal colpotomy. Kong conducted a retrospective analysis of 128 patients with FIGO stage 1B and 2A cervical cancer treated with minimally invasive surgery between 2006 and 2013. Their results showed that the disease recurrence was higher in the group where an intracorporeal colpotomy was performed in comparison with the group where a vaginal colpotomy was used. So 16% here versus 5%, and this was roughly almost significant. So, well, another way to block any contact with CO2 or the peritoneum and the tumor is prior conization. And the most important study here is, first of all, the Kassarin study, which showed that a prior conization leads to a better oncological outcome in patients who were treated with minimally invasive surgery. So these are the results of a multi-center retrospective study with the use of the uterine manipulator and the recurrence rate of 1% pre-conization. So just one cervical cancer recurrence in 93 patients versus 16%, 15 in those who just had a histological confirmation through biopsy and then the hysterectomy without preoperative conization. So these are interesting results showing the protective effect of conization, and the most important study is the Sucker study here, which showed also that conization had a protective effect. The risk of relapse reduced by 65% in those patients who received a prior conization, which is here the blue line. You can see here disease-free survival and overall survival on the right side, as compared to no preoperative conization, which is the red line. The risk of death in general reduced by 75% in this retrospective analysis. Interestingly, there's one study which also showed a better disease-free survival, but a similar overall survival. And this is a study coming from Korea, which I would like to show you here. A large multi-institutional retrospective study showed a lower risk of recurrence. And based on these retrospective data, we have decided now in our department that we perform a preoperative conization prior to any simple or radical hysterectomy for cervical cancer patients. Last, vaginal closure. Also, the Sucker study explored the impact of a vaginal closure on minimally invasive surgical treated patients with cervical cancer. The disease-free survival at 4.5 years was significantly higher in the group with protective vaginal closure than in the group without. This is 93% compared with 74%, and this is highly significant. The minimally invasive surgical group without protective vaginal closure had more than doubled their risk of recurrence compared to the open approach. And the minimally invasive surgical group with vaginal closure had a similar rates compared to open surgery. So in terms of survival, minimally invasive surgical patients without vaginal closure had a 2.85 times higher risk of death when compared with those who underwent an open approach. So these are also retrospective data only. However, they give you a good hint about what is how it is important to provide protective measures if you decide to treat the patient minimally invasive. So the manipulator has also an effect. Certainly, there are more relapses in the Sucker study in the manipulator group than in the non-manipulator group. So 26% versus 16%, and the disease-free survival at 4.5 years was 73% in the manipulator group and 83% in the group without. Tumors higher than in size than 2 centimeters. In this group, the manipulator significantly increased the risk of relapse and in tumors smaller than 2 centimeters, there was no true statistically significant difference between the group with manipulator compared to the group without manipulator. So these are important results which show you that the mechanical manipulation may have an effect on survival. Think also about endometrial cancer patients. So why should it be any different? We used to use the whole manipulator with a sort of manipulative stick within the uterine cavity, and clearly this is a mechanical manipulation that should be at all costs avoided in endometrial cancer patients. So also here, be careful of to use any sort of manipulator in these patients, and it should not be any different than in cervical cancer patients. Yes, there is a learning curve, obviously, also in cervical cancer patient treatment in minimally invasive surgery. So the progression-free survival was significantly poorer in the early learning phase compared with the late phase. And Young et al. Found that the group by surgeon with less than 10 cases per laparoscopic radical hysterectomy had a significantly lower progression-free and overall survival. The surgeon seemed to play a substantial role in the oncological outcomes of patients with early-stage cervical cancer operated by minimally invasive surgery. So as a summary, I'd suggest if you decide to use minimally invasive surgery for a cervical cancer patient, you need to justify it in view of the results of the LEC results, but you can do it if you show adequate informed consent with the patients, and if you show that protective measures have been undertaken, for example, no manipulator, vaginal closure, no further mechanical explanation, and also cervical conization. So this is the end of part 2. And again, I would like to ask you if you've got any questions, which I would be happy to answer at this stage of the talk. Okay. If this is not the case, may I just continue with some slides on the systemic treatment of endometrial cancer patients to close this lecture today. So these are some slides with updated data on the systemic treatment of endometrial cancer patients. And these are results which have been presented at the 2023 ESMO Congress, the 2024 Society of Gynecological Oncology meeting in, I believe this is San Diego, and then also at the Tampa, Florida meeting in 2023. So these are results on the effect of immune checkpoint inhibitors, durvalumab, dostarlimab, and pembrolizumab in 3 different randomized controlled studies. And we do know that these substances have an effect on survival based on phase 2 data coming from Joaquin from Barcelona already in 2020, and Konstantinopoulos in 2019, showing in effect survival benefit in terms of overall response rates in patients which have been treated with dostarlimab or avelumab. So let's have a look at durvalumab first. These are the results of the DUO-E study, ENGOT N10 study, where patients with newly diagnosed endometrial cancer, stage 3 or 4, or recurrence of the disease endometrial cancer have been included into this randomized controlled study. 718 patients were randomized, And the inclusion criteria where that no PARP inhibitors have been given in the past, and the patient should be eligible for chemotherapy. So these patients were either randomized to receive chemotherapy with durvalumab, chemotherapy with placebo, or chemotherapy with durvalumab only. And then in the maintenance phase, they received either placebo, olaparib, or olaparib. So these olaparib, placebo, or olaparib. And the primary endpoint was progression-free survival, and the secondary endpoint was overall survival. The patients were similar in terms of their histology type. Carcinosarcoma patients were included as well. The PDL status was roughly 70% in all groups, and the proficiency status for MMR was 80% in all 3 groups. And what you can see here is that there is an effect of the addition of durvalumab and durvalumab olaparib, especially in MMR patients in this group as compared to chemotherapy alone, with a hazard ratio of 0.42 and 0.41 in these groups. The proficient group benefited the most from the addition of olaparib as well. And in the post-hoc analysis, we can also see here the effect of the additional durvalumab and olaparib combination. Anemia was a frequent adverse event, fatigue as well, and nausea as well. I'm sorry, these are slides in the German language. I hope you don't mind. So this has led to an approval from the European Medical Agency, especially for patients with deficiency. There was a progression-free survival benefit through durvalumab, but also in addition of olaparib with durvalumab in the proficient group. Now let's have a look at the second immune checkpoint inhibitor, which is dostarlimab, and these are the results of the RUBY trial. The RUBY trial was designed to compare patients with stage 3 and 4 endometrial cancer or patients with recurrent disease. The effect of dostarlimab in addition to chemotherapy as compared to placebo, and afterwards dostarlimab maintenance therapy for up to 3 years. The progression-free survival and overall survival were primary endpoints. And unlike the DOE study, we do have results here of the overall survival as well. You can see here that there was in the patient population, a high rate of MSI high patients with 50 and 60% in the dostarlimab and placebo group, and in total similar results. Baseline characteristics, so carcinosarcoma patients were also included here, where as follows: there was a baseline, immeasurable disease at baseline in 90% of the patients in all groups. The primary endpoint, overall survival, is presented here. There is a clear effect, significant effect of dostarlimab, of the addition of dostarlimab with chemotherapy and dostarlimab maintenance afterwards in patients with recurrent or late-stage endometrial cancer, as you can see here. So the hazard ratio is 0.3, which is an impressive hazard ratio. The safety showed that severe adverse events were observed grade 3 in 70 and 60% of the patients. So there was a little bit more toxicity in the dostarlimab group. So again, we do have another option here, especially for MSI high patients, benefiting the most from the addition of dostarlimab and dostarlimab maintenance to chemotherapy in advanced stage disease. And the EMA, the European Medical Association, has also provided approval for this substance. Last, pembrolizumab, and these are the results of the NRG Keynote 868 study. Again, late-stage disease or recurrent disease, 800 patients, either receiving chemotherapy only with placebo maintenance or pembrolizumab in addition to chemotherapy with pembrolizumab maintenance therapy. Again, the primary endpoint here is progression-free survival. So unlike the Ruby trial, we do not have data from the overall survival here. As this is an American study, there was a higher number also from with Black African American patients and Hispanic patients, and most had endometrioid histology patterns, and carcinosarcoma patients were not included. And again, you can see here, there is a survival benefit for patients who had received pembrolizumab in addition to chemotherapy. Here we do have a hazard ratio comparable to the Ruby trial of 0.3, highly significant. And interestingly, this effect was persistent in all subgroups. Again, in the MMR group, there was also a survival benefit through the addition of pembrolizumab, whereas here some subgroups had no statistically significant benefit. The adverse events were fatigue, neuropathy, anemia, and nausea, and these were comparable, however, also to the chemotherapy groups. So the addition has led to a risk reduction for progression or death of about 70 or 43%. So again, we do have a highly effective substance. And the question now is, which substance should we give in which situation? And maybe there is a triage. We do not have any recommendation from our society so far, but let's consider the molecular pathology as being one way to triage the patients. DMMR, maybe these patients benefit the most from durvalumab or dostarlimab as per DuoE results or Ruby results. And maybe PMMR patients benefit the most from pembrolizumab and levantinib. These are the deep results from Christian Mart in Austria, which I've not shown you here, but these are highly significant results as well, but for higher toxicity, or durvalumab and olaparib as the results of the DuoE study have shown. So with these considerations and new updated results for the systemic treatment of endometrial cancer patients, I would like to stop my lecture for today and would like to thank you very much for your attention. If there are any questions so far, please let me know now. You can always also send me an email after this talk.